And yesterday we finished ischemic heart disease. Today we move to another topic regarding CTS pharmacology and the arrhythmic drug. Anti-arrhythmic. The remaining topics left in serious pharmacology, the drugs for hypertension and drugs for lipids and drugs like diuretics. At last, drugs for drugs working like anticoagulants. Is everything we will discuss in CVS, okay? These two done. Now I move on this antiarrhythmic drugs. Antiarrhythmic drugs. What's arrhythmia? If your heart is heart rate, normal heart rate nearly 80, like 70, 75 to 80. The heart is pumping, yeah? It's your normal heart rate. When heart pumping normally with this rate, it means heart pumping, regular heart pumping with rhythm is your rhythm, yeah? So when heart pumping out of its rhythm, heart not follow this rhythm, regular contraction of atria followed by then again contraction of ventricles and heart pumping at constant speed. So when this rhythm disturbs, it's known as arrhythmia. Arrhythmia. Arrhythmia, heart rate, mainly heart rate is affected. Heart rate may be down, heart rate may be up. Understand? It's your rhythm. Heart is not pumping with a constant speed. Maybe heart rate down, maybe heart rate up. So if the heart rate up, it's your tachy. If the heart rate is down, it's your brady. In tachyarrhythmia, in bradyarrhythmia, what's the important event in bradyarrhythmia? Bradyarrhythmia, if you remember, bradyarrhythmia mostly due to blocks. Okay, that block may be in SA node, block in AV node, block in bundle branch, block. Okay, so all the blocks they causing what bradyarrhythmias. So for this thing, for bradyarrhythmias, brady rhythmia two category tachy and brady. For bradyarrhythmias, you have any medication? No. For bradyarrhythmia, we have medication, we have medicine, we have drugs for only for tachyarrhythmia. Understand? For bradyarrhythmia, to increase the heart rate, we're not constantly using atropine, we're not constantly using like epinephrine to increase the heart rate. It's not suitable thing, okay? For bradyarrhythmia, the main issue, the structural problem, AV node and bundle branches, bundle of phase, when this issue there, so we need pacemaker. Understand? We need pacemaker. Artificial pacemaker. Artificial pacemaker. Understand? This part, bradyarrhythmias. If heart suddenly stop, like heart just stop, arrest, cardiac arrest. Then you can give adrenaline. Then you can use atropine. Then you can use dobutamine. So you want to stimulate your heart, yeah? So it is only in case of when heart suddenly stop. This is the only hope we have. So first we give this, then we also, we're giving electric shock to stimulate the heart, yeah? So for bradyarrhythmia, the therapy pacemaker. If suddenly heart stops, then we can use this drug. Okay. Now come to tachyarrhythmia. Why tachyarrhythmias here? Tachyarrhythmia excitation is more. Maybe any ectopic pacemaker, maybe due to current of injury, maybe due to abnormal bundle. If you remember, Wolf Parkinson White syndrome bundle of current is abnormal bundle inside the conductive system, extra bundle. So excitation, the current phenomena, current again and again recycle, re-entry of current is important thing for arrhythmia. So this thing, more excitation, maybe ectopic pacemaker, maybe current of injury, maybe re-entry of the current, maybe abnormal bundle there. Okay. So these are the causes for tachyarrhythmia. So the electrolyte imbalance, alkalosis, pH disturbance. So these are the causes related to tachyarrhythmia. Because in tachyarrhythmia, the heart is working like heart rate is very high. If these tachyarrhythmias related to atria, and this thing is known as supra or ventricular tachyarrhythmias. Okay, if they're related to ventricle, just so it's a ventricular tachycardia, supraventricular tachyarrhythmias, and ventricular tachyarrhythmias. If the problem like in nodal, maybe node sometime have problem, nodal re-entrant, nodal re-entrant, nodal re-entrant arrhythmias. Okay, this is a problem in nodes. So these are all things related to increase heart rate. Understand? So in this supraventricular tachycardia or tachyarrhythmia, the important thing one is atrial flutter, another is atrial fibrillation. Okay. In this, we having ventricular tachycardia and ventricular fibrillation. Clear? So these are all tachyarrhythmias. But tachyarrhythmias, because the heart is moving so fast, so now we focus on some physiological aspect. How heart muscle depolarize? Heart muscle depolarize like sodium. How heart muscle repolarize? Heart muscle repolarize by potassium. Depolarize by sodium and repolarize by potassium. Another thing is how conductive system depolarized by calcium. Conductive system depolarized by calcium. So which system directly stimulate the heart? Like which system directly sympathetic system your beta receptors. Beta receptor. Which one? Beta one. So we're having here the four classes. So four things here. We can excite your heart according to brain physiology. Sodium responsible for depolarization of cardiac muscle. Yeah. So we use here if you block the sodium channel, sodium blocker. Yeah, the first group. And another thing, repolarization issue. If you make a repolarization more, this your depolarization, this your repolarization. If you draw this here like this, so you can see this thing is your time duration, yeah? The 1 week for 1 week, another week. If you block here potassium, so what happens? Repolarization become more longer. It take more time. You can see here. Now time taken here. If you block the potassium channel, so repolarization take long time. Repolarization take long time. If repolarization taking long time, then next impulse will not excite. Okay. So potassium blocker is working here if you block the potassium channel. So potassium blocker also, sodium blocker one group, another group potassium blocker. For conductive system, the all the current to the heart is coming from SA node, AV node, and these two important nodes. How they're depolarized? Calcium depolarized conductive system. Calcium depolarized conductive system. So if you use calcium blocker, okay, if you use calcium blocker, they can block conductive system. Understand? So if they block conductive system, so no more conduction, heart rate automatically decrease. Clear? So this is how these drugs are working. Beta blockers. Beta blockers because they stimulate the heart. If you block the beta receptor, so no more stimulation. So here we having four category of drugs you can use for technique. Understand? Four category of drugs. Sodium blocker, sodium blocker, next one, another beta blocker, another potassium blocker, another calcium blocker. I write a sequence here, not change the sequence, okay? Sodium blocker is your class 1. Beta blocker is your class 2. Okay. Potassium blocker is your class 3. Calcium blocker is your class 4. So not change the class, okay? Sodium blocker class 1. So we having four classes to treat tachycardia. What are the classes here? Four classes. Class 1. Class 1 further types here. Class 1A, class 1B, and class 1C. Clear? Class 1 having three types. So all class 1, what's the name for class 1? These are sodium. Okay? Sodium blockers. So they not allow ventricle depolarization. This topic is a bit quite hard as compared to other severe pharmacology, is more tricky. That's why I'm moving very slowly. Okay? Class 1, another. Class 2. So class 2, what are these drugs? These are bigger. How about the class 3? Not change the sequence, okay. Class 3, potassium blocker, potassium channel blocker. How about the class 4? Class 4, calcium channel blocker. Okay. Potassium channel blocker, sodium blockers, beta blockers, calcium channel blockers, potassium blockers. We're having four classes to treat tachyarrhythmia. Four classes to treat tachyarrhythmia. Class 1 having three types here, 1A, 1B, and 1C. Okay. Till here clear? Antiarrhythmic classes: sodium blocker, beta blocker, potassium blocker, and calcium blocker. Okay. Sodium, beta blockers, potassium blockers, and calcium blockers. So these are four classes we use for tachyarrhythmias to treat the rhythm. So class 1 having further three types, 1A, 1B, 1C. So now first I write the name there, naming of them. 1A, in 1A we having quinidine. The important class here, just very, very important class 1, okay? The more detail about class 1, the remaining are very easy. And class 1B, lidocaine. Class 1B, lidocaine. Class 1C, propafenone. Propafenone. These are one name I just said. Quinidine, another class 1A, disopyramide. Disopyramide. Another procainamide. Procainamide. These three are class 1A. Quinidine, disopyramide, procainamide. Class 2, sorry, class 1B. In class 1B, lidocaine, another. Maxilitine, maxilitine, trocanide, 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 maxilitine, important justice, lidocaine, and maxilitine. Class 1C, propafenone, flecainide, flecainide, okay. Flecainide, propafenone. The students sometimes they mix this with propofol. It's a propofol is different propafenone. Propafenone is a class 1 entry. What is propofol? This we use in anesthesia. Okay, it's a GABA related propofol. Propofol is a drug of anesthesia. It's not belongs. So this is not a sodium blocker. Clear? Class 1 done. 1A, quinine, lidocaine, propafenone. Disopyramide, procainamide, maxilitine, flecainide, procainide. Procainamide, procainide, flecainide. Procainamide, procainide, flecainide. Okay. The class 1A, 1B, 1C. The class 1, 1A, 1A, they have sodium activity, but they're acting on sodium channel. They block sodium channel moderately. Class 1B, they block sodium channel weakly. Class 1C, they block sodium channel very strongly. So 1C is very strong. Must be careful when you're using class 1C because class 1C can cause cardiac arrest. Okay, we not class 1, we not never directly go for class 1C. Class 1C we use when you have no more option. Your rhythm is not controlled by 1A, 1B, and class 2, and class 3, and class 4. Then at last we have option class 1C. Class 1C, we not just like to directly go for class 1C. Class 1C can cause complete cardiac block, okay? Can cause cardiac arrest because class 1C very strong sodium blocker. So if you strongly block sodium, next time that sodium channel will not open to cause depolarization of ventricle. Okay, so class 1A, 1B, and 1C. Understand? Okay, now move on the class 2, beta blockers. In beta blockers, we're using cardio-selective. This you know, cardio-selective beta blockers, atenolol, another bisoprolol. These three are very famous. Another metoprolol. Okay, you can forget other, but not forget these three. Not use here pindolol, acetoprolol. Yesterday I explained because they have stimulating effect also. Atenolol, bisoprolol, metoprolol. Okay, atenolol, bisoprolol, and metoprolol. So these are cardio-selective beta blockers. They go for beta 1. They go for beta 1. Class 3. In class 3, we're having very dangerous drug here, very effective, but lot of side effects. This drug in the antiarrhythmic drug, now we consider this one-man army. It's a one-man army. It can control any type of arrhythmia. The only problem, side effect. It can control any type of rhythm. Iode. having iodine, okay, the rain. So their side effect, hypothyroidism, hyperthyroidism, toxicity, like these are explain, okay, amyloid rain. Amyloid rain, another sotalol. Sotalol. It's like a beta blocker, but also acting on potassium channel. Amyloid rain, sotalol. The calcium channel blocker, yesterday I explained calcium channel blocker, two group, cardioselective, vasoselective. Now you guys let me know which calcium channel blocker class you prefer for arrhythmia to control the heart rate, cardioselective or vasoselective. Which one? Yesterday I explained two classes. Calcium channel blocker, the two types, the cardioselective dipene family, amlodipine, nicardipine, nimodipine, nifedipine, amlodipine, and cardioselective verapamil diltiazem. For arrhythmia, to control the rhythm, we must use cardioselective. We must use cardioselective because these drugs act on heart, okay? The other calcium channel blocker, they act on vessels. They cause vasodilation. Not use the vasoselective calcium blocker here. We for to control the rhythm. These drugs act on conductive system, cardioselective. Two drugs, one diltiazem, diltiazem. Another verapamil. So these two are calcium channel blocker class 4. The naming done, potassium channel blocker, amiodarone and sotalol. Class 3, potassium blocker, amiodarone, sotalol. Class 2, beta blockers, atenolol, bisoprolol, metoprolol. And class 1, sodium blocker, big family having further subclasses 1A, 1B, 1C. Clear? 1A, 1B, and 1C. Clear or not? This class is done.
Yes, sir.
Quinidine here. Now I am putting some important points regarding class 1. The class 1, this 1A, right? Another thing, very important thing here. This class 1A also act like class 3. Act like class 3. Listen here carefully. Class 1A, what is class 1A? It's a sodium blocker. Yeah, it belongs to sodium blocker. And what is class 3? It's a potassium blocker. Class 1A also work like class 3. Class 1A work like class 3. Clear? And now see here, what's the class 3 doing? The class 3 can act like class 1, can act like class 2, can act like class 4. It means that's which one? Amiodarone. This one. This amiodarone can block sodium channel. Okay, focus here. This is a class 1. Can block beta receptor is a class 2 here. Can block calcium channel is a class 4 here. It belongs to class 3. So that this is the reason why I give the name amiodarone is a one man army. Amiodarone can control any type of arrhythmia. The only drawback, the negative aspect of amiodarone, side effect. Understand or not? Okay. So amiodarone have ability to block sodium channel, have ability to block beta receptor, have ability to block calcium channel, have ability to block potassium. You can see here all the things blocked by one drug. Understand? All the things blocked by one drug. That's the amiodarone. So class 3 have activity of all other classes. That's your amiodarone. Understand? Class 3, it belongs to potassium channel block. It's a potassium blocker. Block potassium channel, block calcium channel, block beta receptor, block sodium channel. Done? class 3. Okay, now the class 1A, now come back to class 1A. Class 1A have ability to block potassium channel. So write this sentence, class 1A belongs to sodium blocker. Yeah, class 1A belongs to sodium blocker. Also have ability to block potassium channel. So it means class 1A also act like class 3. Clear, clear? Class 1A also act like class 3. Okay. Next one. Come to B. Anything special to B? Yes, very special thing. Class 1B, the patient having MI. Okay. After MI, what is the most common cause of death within 24 hours? Listen here question clearly. What is the most common cause of death within 24-hour heart attack? Why patient die? Morning have heart attack. Now in emergency, okay. Now in emergency, is patient stabilized, okay. At night, patient die. Why patient die within 24 hours? What will be the answer? Number one, arrhythmia. Number two, cardiac tamponade. Number three, sudden cardiac death. Number four, pericarditis. They are complication of MI. So which complication is very dangerous and most common within 24 hours? Why patient die within 24 hours? Can you tell me the cause? Need knowledge of pathology here. If the patient have MI, okay, that patient die within 24. It means within 1 day patient die. Why patient died within 24 hours? Because of arrhythmia. Understand? Because of arrhythmia. The cause of death within 24 hours, arrhythmia. Within 24 hours, arrhythmia. So now come back here. The post MI, if the patient, of course, patient have chance of arrhythmia. I already explained here. Now come back here. So what will be the cause of tachyarrhythmia if you focus here? The current of injury. Yeah, the patient having MI, patient have MI. That's your ectopic work like ectopic. That injured part also depolarize. That injured part disturbs the normal tissue of the heart. That injured part in causing here tachycardia, and the patient now can have tachyarrhythmia. Well, dangerous tachyarrhythmia, maybe ventricular tachycardia and ventricular fibrillation. The patient can die easily. Yeah. So what's the importance of class 1B? Must keep in mind this one. The class 1B very effective in post MI arrhythmia. Understand or not? You know, every patient here, 80 to 90%. The heart diseases we having atherosclerosis, coronary artery disease is a big killer related to heart. The other disease like cardiomyopathy, valve disease, rheumatic heart disease, infective endocarditis, these diseases not kill the person like suddenly like this, and their incidence is also low as compared to coronary artery disease. The main key thing here related to heart disease, ischemic heart disease. Understand? So coronary atherosclerosis, diabetes, hypertension, obesity, smoking lead to atherosclerosis. Atherosclerosis causing coronary artery disease. Coronary artery disease cause angina. Angina plus MI. This is the main key thing here related to heart pathology. Understand? So the most common cause of death related to heart, coronary artery disease. Done? Why? Because patient now having MI. So in MI, why patient die in MI? Because of arrhythmia. Understand? After MI, patient have arrhythmia. Why arrhythmia? Current of injury there. So this drug is a golden drug. It's a golden drug for my life. Understand? It's a very important class 1B. That's the importance of class 1B. Not forget this importance of class 1B. You can forget every drug belongs to antigen. Never forget this. Okay? Class 1B is a life saving for MI patient. Done? Okay. Now patient, what's the difference between these three drugs I written here? If the patient now in hospital admit, you give IV. Lidocaine is not available oral. Patient have MI, now patient admit in hospital in emergency. Yeah, the patient now receive management and drugs in hospital. So antiarrhythmic drug in hospital class 1B lidocaine, because lidocaine only can given IV. So IV in hospital mostly, of course, the patient have much severe condition, and we can use IV intravenous drug in hospital. Yeah, and when the patient come back to home, patient still have chance of developing arrhythmia. So these drugs use orally. Understand what's the difference between lidocaine and mexiletine and trocanide? Trocanide, mexiletine. Trocanide and mexiletine we can use at home when patient now stable, come back after the management. The oral class 1B, mexiletine, trocanide. IV class 1B, lidocaine. Clear, clear? Can you tell me any sodium blocker in CNS epilepsy lecture? Epilepsy drugs, sodium blocker also, calcium blocker also, glutamate related. Yeah. Any sodium blocker have sodium channel block property. Valproic acid, phenytoin. The phenytoin also have ability to block phenytoin. I just add another drug, phenytoin. Okay. What's a phenytoin? Phenytoin is a drug for CNS. Yeah, it's a drug for epilepsy. And what is the action of phenytoin? Sodium block. This sodium block preferably inside the neuron. Listen here carefully. This phenytoin give me extra benefit. This sodium block also on heart. Sodium block also on heart. This is a dual benefit of phenytoin. So phenytoin, which group I can put this phenytoin here? The class 1B, add another drug, phenytoin. Okay, class 1B, add another. This drug actually belongs to epilepsy, but we can use for arrhythmia. Okay, phenytoin. Phenytoin. Also IV in hospital. Lidocaine, phenytoin. Understand? So class 1B. What's the importance about class 1B? Class 1B used if the patient have heart attack. After heart attack, patient have arrhythmia. That time, your drug of choice must be class 1B. Later I explain why after MI, okay? Later I explain this thing. Okay, now come to another thing. Quinidine. I'm describing one by one, okay? Quinidine, what's a quinidine? Quinidine causing what? The quinidine, if you remember quinine, yeah? What's a quinine? You remember quinine? What is quinine? Quinine comes from cinchona trees used for malaria. Chloroquine, meplequine, premaquine, quinine. Quinine come from which tree? The tree name, cinchona. Which tree? Cinchona. Quinine. This quinine we use for malaria. Yeah. So I think the if you focus the name here, quinine, quinidine, what the difference here? No difference. It's still same thing. Quinidine, little structural difference there, but the same thing. So quinidine also derived from cinchona tree. The side effect of quinidine, synchronism. Let us explain what is synchronism. Synchronism. In synchronism, what happened? Number one, GIT upset. Synchronism. GIT upset. Second, headache. Third one, tinnitus, ringing sensation in ear. Headache, headache, one. GIT upset, two. Number three, tinnitus. Tinnitis. Tinnitus. Tinnitus, ringing sensation is your synchronism. So synchronism is a side effect of unity. Synchronism is a side effect of unity. Okay, now come to disopyramide. Disopyramide can cause heart failure. Okay, now come to procainamide. I am telling you the important aspect. Okay, every drug, each and every drug. Procainamide causing what? SLE. If you remember any other drug for SLE, SLE. Hydralazine, remember? SLE. Side effect related to SLE, hydralazine. Side effect same like SLE, lamotrigine, ethosuximab, phenytoin, carbamazepine. Anti-epileptic. They have ability to stimulate your immune system. Okay, the drug causing SLE, anti-arrhythmic drug causing SLE, procainamide. The drug belongs to severe system cause SLE. Number one, we done in heart failure. If you remember hydralazine, yeah, arterial dilator. Hydralazine, SLE. Procainamide belongs to antiarrhythmic class 1A causing SLE. The side effect of procainamide, SLE, the side effect of heart failure, diazepamide is a heart failure. The side effect of quinidine is synchronism. Understand? The side effect of